Every heartbeat depends on a constant supply of oxygen-rich blood. But when the coronary arteries become severely narrowed, the heart muscle can become starved of oxygen. In selected patients, doctors may recommend coronary artery bypass grafting, or CABG, to create a new path for blood flow. In this video, we will explain the indications, contraindications, mechanism, and methods of conventional CABG and minimally invasive coronary bypass surgery. This video is for education only and is not a substitute for advice from your own cardiologist or cardiac surgeon. Coronary artery disease usually develops when fatty plaque builds up inside the arteries that supply the heart. As the channel becomes narrower, less blood reaches the heart muscle, especially during exercise or emotional stress. This can cause angina, shortness of breath, fatigue, or, if a plaque ruptures and a clot forms, a heart attack. Medicines, lifestyle changes, stents, and bypass surgery are all tools doctors may use, depending on the pattern and severity of disease. CABG does not remove the plaque from the diseased coronary artery. Instead, it creates a detour. The surgeon takes a healthy blood vessel, called a graft, from the chest, arm, or leg, and connects it so that blood can flow around the blockage. One end receives oxygen-rich blood, and the other end delivers it beyond the narrowed segment. The goal is to restore blood supply, reduce ischemia, relieve angina, and, in certain high-risk groups, improve long-term survival. Guidelines from the ACC, AHA, SCAI, ESC, and EACTS all stress that revascularization decisions should be individualized. A heart team approach is especially important when the best choice between medicines, stents, and surgery is unclear. CABG is often considered when coronary disease is complex or extensive. Important examples include significant left main coronary artery disease, diabetes with multivessel coronary disease, triple vessel disease with suitable anatomy, and reduced left ventricular ejection fraction in selected patients. CABG may also be considered when angina remains uncontrolled despite optimal medical therapy, or when PCI is not technically suitable or has failed. The decision is not based on one artery alone. Doctors look at the coronary angiogram, the syntax score or anatomic complexity, heart pumping function, diabetes, kidney function, frailty, bleeding risk, patient goals, and expected benefit. There is no single universal contraindication that applies to every CABG decision, because the choice depends on the balance of risk and benefit. However, surgery may not be suitable when the operative risk is prohibitive, when there are no good target vessels for grafting, when the heart muscle supplied by the artery is no longer viable, or when severe non-cardiac illness, uncontrolled infection, major bleeding risk, or extreme frailty makes recovery unlikely. For minimally invasive direct CABG, patient selection is even more specific. Mid-CAB may not be appropriate in severe COPD that prevents single lung ventilation, severe left subclavian artery disease affecting the internal mammary artery, hemodynamic instability, emergency situations, very small or deeply embedded LAD arteries, severe chest deformity, or very complex coronary anatomy. In conventional CABG, the patient receives general anesthesia. The surgeon usually opens the chest through the breastbone, called a median sternotomy. Grafts are prepared from vessels such as the left internal mammary artery, radial artery, or saphenous vein. In on-pump CABG, the heart is temporarily stopped, and a heart-lung machine maintains circulation while the surgeon sews the grafts onto the coronary arteries. In off-pump CABG, the heart continues beating while a stabilizing device holds a small area still so that the graft can be sewn safely. Each graft is connected to bring blood beyond a blockage. After all grafts are completed, the surgeon checks flow, closes the chest, and the patient is monitored in the intensive care unit. The exact number of bypasses depends on how many important arteries need treatment. The choice of graft matters because long-term success depends partly on graft durability. The left internal mammary artery, also called the left internal thoracic artery, is usually preferred for the left anterior descending artery, or LAD, because of excellent long-term patency. The 2021 ACC/AHA/SCAI guideline also gives strong support to using the radial artery rather than a saphenous vein for the second most important target vessel when the radial artery is suitable. The saphenous vein from the leg is still widely used, especially when multiple bypasses are needed. But vein grafts can narrow over time, so surgeons balance anatomy, urgency, patient risk, and conduit quality when planning surgery. Minimally invasive direct coronary artery bypass, or MIDCAB, is designed to reduce surgical trauma by avoiding a full breastbone split. Instead, the surgeon reaches the heart through a small left-sided chest incision, often about 5 to 8 centimeters, usually between the ribs. The most classic MIDCAB operation connects the left internal mammary artery to the LAD on the beating heart. The surgeon uses special retractors, stabilizers, and magnified visualization to harvest the artery, and so a precise end-to-side anastomosis. Some centers also use robotic or totally endoscopic techniques to help harvest the internal mammary artery and reduce incision size further. MIDCAB is most commonly discussed for isolated proximal LAD disease. In selected patients with disease in other vessels, surgeons and cardiologists may combine minimally invasive Lima-2 LAD bypass with PCI to other arteries. This is called hybrid coronary revascularization. After CAB or MIDCAB, recovery includes monitoring, pain control, breathing exercises, wound care, heart rhythm observation, and gradual mobilization. Long-term success also depends on secondary prevention. Antiplatelet therapy when prescribed, cholesterol lowering, blood pressure and diabetes control, smoking cessation, cardiac rehabilitation, healthy diet, and regular follow-up. Bypass surgery improves blood flow, but it does not cure the underlying tendency to develop atherosclerosis. In summary, CAB creates a new route for blood to reach the heart muscle. Guidelines support CAB in selected patients with high-risk anatomy or persistent symptoms, especially when decisions are made by a heart team. Conventional CAB can treat multiple vessels, while MIDCAB offers a less invasive option for carefully selected patients, especially LAD disease. If you found this explanation useful, subscribe for more clear medical animations, and always discuss your own treatment plan with your healthcare team.